Think about weaning strategies for VA echo.
Hi, thanks very much for the introduction. Thank you for having me. Just waiting for my slides to go live. Thank you. I've got no disclosures related to this or any other presentation. Okay, so in the next 10, 15 minutes or so, I'm going to talk a little bit about the nice bit of extracorporeal support, the bit where you're expecting to be able to take the patient off and move them to the next phase of their illness. And I'm divided into these different parts. So the first is a bit about expectations, a bit about why weaning fails, which may seem very obvious, but sometimes it's not so obvious, a bit about what we know about predictors of success. I'll take you through some of the strategies and different ways that people wean, and at the end I'll give you what we do. I'll give you just a hint about some potential additional tools you might consider using in your armamentarium, and then I'm going to talk a little bit about what actually success looks like. So I'd start by saying not all cardiogenic shock is equal, and that reminds us that it's a syndrome, it's not a diagnosis. And when you're considering weaning the patient, you have to be very aware of what the underlying diagnosis is, because you may have different strategies depending on where they're coming from, and you certainly will have different expectations. So the commonest group, the patients who have cardiogenic shock because of myocardial infarction or acute coronary syndromes, they're some of the most challenging patients, mostly because of their comorbidities, and how you wean them and the kind of devices you will use both initially and how you will wean them using different devices may be different from other patients. The post-cardiotomy patients are particularly challenging, and you'll get great outcomes if you're very strict with your application of criteria like the Bartlett criteria, and you need to know where that patient came from in terms of determining how you're going to wean them. You have a nice group in terms of pulmonary embolism and patients with sepsis-related cardiomyopathy. Pulmonary embolism, you may not be coming from VA ECMO, you may have an oxy-RVAD in position, so your weaning strategy will look very different. And then you've got other groups of patients. So peripartum cardiomyopathy, you have to be thinking about your other interventions, for example, bromocriptine, and where that patient will be in terms of, is this heart likely to recover, yes or no? And with peripartum, we'd be speaking to our transplant surgeons if it's looking like not. And then you have some extraordinary patients that are emerging because of the increased use of extracorporeal support that would not otherwise have survived. So, for example, we had a patient who took a sodium azide overdose, and sodium azide is a close relative of cyanide. And when we contacted the poisons unit, they said this is unsurvivable, this is irreversible mitochondrial inhibition. Well, it turns out it's not irreversible. And so you have patients that you really don't know what the outcome is likely to be because you're moving into uncharted territory. Next up, you have to think about how long you would expect that patient to be on ECMO, depending on how rapidly you'd expect the heart to recover. And there are a number of studies that have looked at this, different etiologies, different patient groups, but it could be anything from 48 hours in one study up to 11 plus days. So when you're approaching your patient, you've got in the back of your mind the underlying etiology and where they are in terms of their trajectory of improvement. And then you start thinking about, why are you trying to get this patient off? And different scenarios will drive you to do things at different rates. So first up is, what is your expectation of success? Do you think that this patient is going to wean now? You know, is it the first 48 hours down the line you're just having a look, or is it actually you're really, really confident that you're going to get this patient off because you've seen that they've been improving day by day? Sometimes you're driven to take the patient off earlier than you would like to in suboptimal conditions because you're running into difficulties with the circuits and anticoagulation and others, so you have to take the patient off. You have to look at your patients with potential to downgrade the level of support they've got. And we talked earlier today about, you know, if you have an ECMO and an impeller, would you be winning the ECMO first or the impeller first? And generally, we would be taking the ECMO off first if we had combined devices. And if we have got isolated right heart failure and the left heart's recovered, we'd be moving to isolated right-sided percutaneous support. You have to be thinking about, well, is this patient going to need a longer-term device? Are they really not going to wean? In which case, right from the start, you need to be speaking with your VAD and transplant colleagues. And then occasionally, unfortunately, you will be weaning to futility. And what that wean looks like, you need to prepare the whole team for. That said, you've decided that you're going to go to wean. You also need to have in the back of your mind, why might weaning fail? Is it the right heart? Is it going to be the left heart? Or may it be the lungs? And before you move towards weaning, you have to have that absolutely in the back of your mind as to what you expect this patient to do. Now, common to all weaning strategies are some prerequisites that need to be there, and there are other things that we can look at that may suggest that the patient will recover earlier or not. So there are some things we can't do anything about, so the etiology, the age, the sex, and whether they've had CPR before they go on. We know that's associated with less good outcomes. But certain things will suggest to you this patient might do better. So not just the etiology, but an early recovery of pulsatility, an early recovery of cardiac index, an early clearing of the lactate and other biomarkers of injury. And then there are some echocardiographic parameters, and Alain Coombs and his group did some of the first studies in this, looking at which patients would be likely to predict to come off VA ECMO. And these involve early on looking at left-sided VTI, the ejection fraction, and tissue Doppler imaging, particularly of the lateral mitral annulus. We're moving now to look at 3D right ventricular ejection fractions. We've now got studies emerging with global longitudinal strain. And a nice study recently published looked at the corrected left ventricular ejection time over the pulmonary capillary wedge as a potential predictor of weaning success. So I'm now going to take you through 6 different strategies. I'm not going to walk you through each stage because most of the people on this call are going to be pretty experienced at this, but I'm just going to point out some of the key differences between the different weaning strategies that there are. So prior to all of them, the question is, are the patients potentially weanable? So all of these strategies suggest that you must have addressed the potentially reversible issues, not just from the initial admission, but if there is an unexpected or tamponade, for example, that's probably not the time to be trying to wean your patient. You need to fix those first. They pretty well all say the patient should be on no or minimal inotropic support. They should be stable in terms of their hemodynamics. Their fluid balance should be acceptable, whatever that means. They should be electrically stable and no evidence of ongoing ischemia. And depending on whether you're combining with, for example, an impeller, maybe some other hemodynamic parameters. So these are sort of taken as read for these 6 following strategies. So this is the first strategy. So you've got everything stable, and you're making sure that the lungs are good enough before you try to take the patient off, and you gradually wind down your ECMO flow to 2/3, then 1/3 of the baseline to 1 to 1.5 liters a minute. And then you're using either echo or hemodynamic parameters to suggest that the patient is weanable. Strategy 2 is slightly different. It's the same again, everything's nice and stable before you start, but this is using a combination of hemodynamics and echocardiography to predict whether the patient might wean successfully. Strategy number 3, again, uses echocardiography and hemodynamics, then comes back again and does more echocardiography and hemodynamics. And strategy number 3, it talks about what to do if the patient won't come off in terms of your longer term strategy. Strategy number 4 is quite different. So strategy number 4 is one that uses entirely echocardiography. So it uses one of the miniaturized TOE probes. The probe goes down. You decrease the flow in increments down to about 1.5 to 1.5 liters, and you keep looking at the left ventricle. If the left ventricle doesn't dilate, they then suggest that you volume load the ventricle. If both biventricular failure function stays the same, they then suggest that you load inotropes and then try to wean the patient. So no hemodynamics, just all based on echocardiography. This is a strategy that's used widely in pediatrics. It's not one that we use in our institution for our adult patients, largely because our lead for MCS is not a big fan. And the reason he's not a big fan is this. It's that in this strategy, it's pump-controlled retrograde trialing off. And what you do is you gradually wind down your ECMO flows. Once you've got retrograde flow at about 0.5 to 1 liter, you've obviously had to turn your flow sensor in the opposite direction. You take off your sweep gas, you assess the patient over the next hour, and if they're looking stable and they're looking good, you think about then taking the patient off ECMO. Now, the reason that our MCS lead here at Brompton doesn't like this is he feels that what you're doing is taking a heart that is struggling and then giving it a shunt to deal with, and he just intellectually finds that a bit of a struggle. Our pediatric ECMO experts, by contrast, use this all the time. So not one that we use in adults, but it is one we use in children. And then strategy 6 is a very slow wean. So it's a combination of echocardiography, hemodynamics, a very, very slow wean, and then leave the patient at a relatively low flow, appropriately anticoagulated for 12 to 24 hours. Then a further echocardiographic study, and then try to take the patient off. And again, what they do in this strategy is they're very clear before they take the patient off is if the patient fails to come off, what are you going to do? So there's a clear plan. It's not made in a hurry at the end. This is what we do here at the Brompton. So it's really a combination of most of these. It's for adult patients, as I say, not the pediatric patients. We use a lot of echocardiography. And we make sure that everything is perfect. We've reversed everything we need to. We do a fairly rapid, depending on how good the heart is and how keen we are to take the patient off. So we're integrating and synthesizing all of the factors that I've mentioned earlier. And then one of three things will happen. One will be, it'll be apparent that the lungs aren't good enough. That's usually not a surprise. And then we may downgrade to VV ECMO. It may be that we're very, very successful, in which case at that point we'll float a swan if there isn't one in already, and we will leave the patient for between 2 and 8 hours, and then we will decannulate the patient if all's looking good. And then one other thing that we do is if the cardiac output is falling, measured by your VTI and or your swan, then what is really key is to differentiate whether it's the left heart or the right heart that is causing your problem. And to do that, in addition to standard echo parameters, we look at some physiological echo parameters, and one is the left-sided total isovolumic time. So for those of you who aren't familiar, the cardiac output and index normally go parallel with the total isovolumic time. So that's a wasted time in any heart cycle. And if the cardiac output and index goes down, you look at the total isovolumic time and you would expect to see that the total isovolumic time either stays the same or goes up. If the cardiac output and index goes up, you'd expect the total isovolumic time to go down. So if a patient is failing to wean and the stroke distance on the left side drops, and you see that the heart is getting more efficient because the total isovolumic time is also getting shorter, you should look to the right heart, because it's the right heart that's not delivering adequate preload, and that's telling you, that's showing you numbers that you can measure very easily, very reproducibly, why. So the additional prior tools I'd say prior to weaning is make sure you've got your critical care basics right. Make sure you're using your echo smartly. Make sure your cardiac electromechanics are good. So if you've got biventricular pacing or AV pacing, make sure you've optimized them before you try to wean as well. Please don't forget the right heart. Look after the right heart, because it may be the reason that your patient is failing. And then finally, when you're looking at trials that look at success for weaning, be very, very careful what you look at in terms of outcomes, because they're very, very different in different papers. So is it survival to decannulation or discharge? Is it survival to transfer, 30-day mortality, 1-year mortality? Have they put recannulation rates in there? And does anybody in the study looked at quality of life or any patient-reported outcome measures at the end? So this is really what I've been through with you, a bit on expectations, a bit on why weaning fails, some predictors, some different strategies with subtle but important differences, additional tools and markers of success. And my take-home message is really, when you're approaching weaning a patient, is firstly, make sure you know the direction of travel for your patient. You need to know everything about them. Anticipate what success and failure looks like, and make sure you know that the team are bought into whatever it is you're going to do should you fail. Please don't disadvantage your patient by doing a suboptimal weaning study in suboptimal conditions. Remember that no one weaning strategy is yet being demonstrated to be better. And if weaning fails, make sure you absolutely understand why. Is it the left heart, the right heart, the lungs? And what can you do to reverse to make sure that patient could possibly wean successfully? So thank you very much for your attention.
Thank you very much, Susanna, for this nice, very comprehensive presentation. Now we switch to the next pro and cons. Actually, we have, unfortunately, Professor Enrique